Welcome, everyone, to the first episode of our case series, Optimizing Care in Community and Safety Net Settings, sponsored by the Journal of the American College of Radiology. This is a forum for radiologists, technologists, trainees, and hospital leadership to share knowledge about overcoming patient level and community level barriers to support high quality care, innovation, and public health efforts in the community and safety net environments. We have 4 sessions planned during each quarter of this academic year, covering a variety of topics in different subspecialty areas of radiology. We are aiming to fill a gap and increase discourse about issues facing community and safety net settings in radiology, where the majority of care is being performed. Our session today will be focused on breast imaging in community and safety net settings. I am Randy Miles, Chief of Breast Imaging at Denver Health. In terms of our hospital cares for nearly 25% of Denver's population annually. We are considered a safety net hospital tasked with providing care for the most vulnerable and underserved sectors of the community. We have an amazing group of radiologists and hospital leaders, including our chair, Dave Nager, that's really worked to provide the highest quality of care in this setting. We have worked through issues including access, reducing a 60-day wait time for screening examinations to less than 3 days. We have reduced our report turnaround times from 2 days to less than 2 hours for our breast imaging exams. We've really focused on access and quality, establishing same-day screening events, and have established a same-day biopsy program. Lastly, we have created quality educational measures that have significantly increased our cancer detection while reducing our callback rates to less than 10%. So I'm excited to talk more about these initiatives with our guest. But first, a few announcements. For any medical students or programs with medical students, we really want to highlight Medical Student Hub, which you can find at acr.org/medstudent. Want to point out that ACR membership for medical students is free. And for medical students, you can utilize this resource for volunteer opportunities, scholarships, and community. And we actually offer a free ebook when you join that provides all the information that you need about becoming a radiologist. In addition, there are numerous upcoming events being hosted by the ACR Med Student Subcommittee, including Medical Student Journal Club on September 27th, and a talk on LinkedIn and virtual professional presence on October 12th. And then lastly, if you want to continue the conversation after the episode today, please join us on engage.acr.org, which is a forum for ACR members to link with peers from similar practice settings, goals, and from similar practice settings with similar goals and similar challenges. We will be monitoring the feedback from this session, posting questions, and looking for input on future topics and speakers for our case series. So I'm really excited to get started and to introduce our first featured guest, Dr. Amy Patel. Dr. Amy Patel was born and raised in a rural town in Missouri, which inspired her goals of closing the gap of breast care disparities in breast imaging and ensuring access to care for all patients. She completed her breast imaging fellowship training at Mallinckrodt Institute of Radiology at Washington University, and is currently the medical director of the Breast Care Center at Liberty Hospital. She holds numerous national leadership positions, including being the current chair of the American College of Radiology Advocacy Network, and RADPAC. Welcome, Amy. Can you tell us a little bit more about your work and Liberty Hospital, where you practice?
Sure. Well, thanks for having me today. I'm looking forward to this discussion. I am very honored to be the medical director of the Breast Care Center at Liberty Hospital. Liberty Hospital is a community-based hospital that's in the Kansas City, Missouri metro area. And then in addition to that, given that I am, by strict definition, a managing partner in a private practice called Alliance Radiology. We also, through Alliance, serve multiple critical access care hospitals in Northwest Missouri, 7 of which I am the lead interpreting physician of, in addition of being medical director at Liberty. And I also am lead interpreting physician of a federally qualified health center in downtown Kansas City called Samuel U. Rogers. Given that we have these different practice, settings in the sense of, a critical access care hospital, community based, federally qualified health center where, those of you who know what an FQHC facility is, it's where you're funded federally by the government, and you serve predominantly underserved patients. You can't really turn anyone away, just like a safety net hospital. We're able to sort of work together to make sure if they need advanced testing, and with that access, they can come to Liberty. And we can talk about that a little bit more throughout the hour. So that's kind of my practice setting. It's a lot of different moving pieces, but somehow we make it work to make sure that patients have access.
Sounds great. So we'll start off with our first question. I do want to encourage everyone, if you do have questions, please, type those in the comment box, and we'll try to answer those as they come through. So, Amy, what do breast imaging patients want from their breast imaging centers these days?
I think patients want transparency. I think patients want accuracy as well. I think we take for granted these days how much a patient really knows. Yes, there is so much on the internet that may not be entirely accurate, but, there is a lot of accurate information. And I think that patients have a thirst for knowledge. I'm seeing that more and more as I, continue on with my career. And they want quality, I think that that's really important, and that's something that, the field of radiology, whether you are hospital employed working for a nonprofit, whether you're working for a safety net, you're working for a for-profit, you're working in the outpatient imaging setting, I think that quality is something that should not suffer, and it's something that we need to focus on for our patients. And I think just compassionate care. I think that we're doing a great job, particularly in the field of breast imaging, to come out of our dark rooms to talk to patients. Those of us who do speak to patients, we're trying to get the word out more that we shouldn't just rely solely on the technologists who are our wonderful frontline workers when it comes to our patients, but being that patient facing and providing compassionate, empathetic care. It's not just about the technologist; it's the radiologist as well, and just as a multidisciplinary team. Every week we get our Press Ganey surveys from patients who've filled that out and who we've sent the link to. And, by and far, the comments that we get the most is how they were treated. Were they treated with dignity, respect? Were they provided compassionate care? I think that those are really, really important, and things that as radiologists, we may not think about as much as maybe other subspecialties, but I think that it's equally important to place an emphasis on.
Yeah, I think you make a great point. And as patients are coming in, they're really starting to want that education from radiologists and breast imagers. And that's an area where we definitely can make a great impact. Even if you don't see the patient, just offering that you're willing to come in and talk to them for, negative or benign results. It really does help those scores, as you mentioned. I'll add to that. In addition to education, I think proximity, patients. I think kind of we had this kind of post-COVID or COVID effect where patients really want to have that convenience of going to sites that are closer to their home. I think that's really lasted. So any way you can bring care to the patient, I think it's really going to help improve, access and also patient experience. So, and then we'll go to our next question here. You talked about your practice and how varied it is. What do you think are the biggest challenges facing practicing breast imagers in the community right now?
Yeah, I think one of the biggest challenges we face is the shortage of radiologists, of breast imaging specialists. I think more and more hospitals, health centers, outpatient imaging centers are looking to hire breast imaging specialists to read the breast imaging. And we have, we don't have, and this is something that we continue to discuss, that we need to increase the number of residency positions, which we're vociferously trying to do so through Congress. Just with wearing my ACR hat, I know what's happening behind the scenes with us trying to push for the increased number of residency slots, so that hopefully translates to more in the workforce. We have so many radiologists retiring. We saw that, specifically starting with the pandemic. It's continuing, and so that is an issue when you don't have enough radiologists, breast imaging specialists. The volumes continue to grow. That's a really big issue. I think that, access still continues to be an issue. I think that, for example, in our city of Kansas City, we truly, by strict definition, only have one health system that is, by strict definition, a safety net hospital, whereas the rest of the health systems aren't. But just because they aren't a safety net hospital doesn't mean that these other hospitals aren't trying to make sure that patients have access. At our hospital, we have a foundation where if you're at the 200% poverty level, that we don't turn patients away. We'll cover them, whether it's for a mammogram, an ultrasound, and a biopsy, all the care. And then we have a patient advocate, financial assistance. We really try to work with patients so that we don't turn them away. But we still have a lot of financial challenges in multiple different states. And for example, where I practice in Missouri, we have some of the highest breast cancer death rates in Black and Hispanic women. The number one county where we have that is where I grew up in Livingston County, and that still is continuing on. So we have a lot of work to do, I think. But I would say that, every part of the country is going to be a little bit different. But specifically, where I practice, and just overall, I do think the biggest issues are not having enough radiologists, and we still have immense access to care issues.
No, definitely great points. Amy, have you seen similar patterns with technologists and kind of the ancillary staff as well? I know that's something.
Absolutely. I mean, that's another issue. We have a shortage of technologists across the country. Once COVID happened, and then we paused routine screenings and then resumed them, we had a lot of technologists just retire. They were done, and we're still having, problems with staffing. We still have a lot of traveling technologists. I'm really fortunate in the sense that where I practice in sort of my hub of facilities and at Liberty, we do pretty well with staffing, thankfully, but we still have had some facilities where some people are just going ahead and retiring. So we don't have, as many of these staffing issues as I'm hearing from other colleagues around the country, but it's still another issue. And again, we talk about the radiology shortage. I think the technologist shortage is something that we're really going to have to address head on.
Yeah, definitely agree. And I think that's something, in our practice, we really, I know Amy probably can echo some of these points as too. We really tried to work smarter and try to be more efficient and really have everyone working at the top of their license. One of the big things that we did was to, with these shortages, with breast imagers, with technologists, we hired a medical assistant. And that's someone, that came in able to help with ultrasound biopsies, able to help with like calling patients, really able to help free up time for the existing technologist on staff so that they can be working to be performing the mammograms, performing ultrasounds, and just kind of unloading some of the additional tasks that may be preventing them from completing the work of a technologist.
Yeah, and another thing that we did that's helped is we any new hires now, we're cross training them in mammography and ultrasound. And yes, that is a lot of work. It's a lot of work for the other technologists that are helping train. It's a lot of work for the radiologists, specifically for me. I'm very hands on. I like to teach and that kind of thing. But, once you can get them certified, it's so wonderful to have, these techs where, we now have 4 technologists who are cross trained so that if somebody calls in sick or if somebody, has an extenuating circumstance or is on vacation or something, another tech can hop right in. So we're seeing that trend too across breast centers across the country, just cross training technologists to help with the shortage.
No, great advice. Can we, we'll move to the next question here. And I think we've touched on this a little bit, but how does breast imaging practice differ, whether in the outpatient, community, academic, and remote setting? What are some strengths? What are some challenges?
Sure. So it can really vary a lot. So, an outpatient setting might that breast practice might be under the purview of like a for-profit private practice, and so they may not have or and I don't mean to generalize, but if you're a for-profit practice, you may not be able to offer, or you may just not provide the same sort of access to care resources, particularly to those who are underserved, who don't have insurance, who are underinsured, or it could be an outpatient setting that is affiliated with like a nonprofit hospital, let's say, where they can provide access. So there's quite a lot of different flavors there. Of course, in an outpatient setting, if you're an outpatient imaging center, you may not see that continuity of care with patients as you would at a breast center that's maybe hospital based or in a community or academic setting. I would say that, in the remote setting, it can be very, very challenging. So specifically, I talked about how I oversee the breast imaging for critical access care hospitals and a federally qualified health center. So myself and my colleagues, we read the breast imaging for these facilities remotely. We read these images from the main hub, Liberty Hospital, for all of these facilities. And remote interpretations, as many breast imagers know, can be very, very difficult. You're not there to scan the patient, for example, for if the patient has an ultrasound, you're not really sure what you're seeing. The communication can break down. So it can be really, really challenging. And so you have to be a little bit more hands-on with remote interpretations. It can you can do it, and you can provide quality care in the remote setting, but it takes a lot more effort. So I would say that out of anything I do for my job, I do think remote interpretations, remote care is the most challenging. I think if you talk to our technologists who are on the other side at these hospitals and facilities, they would also agree. They know it's challenging too. But if you're truly committed to making sure you're providing as best of quality care as you can for the patient, then we have to be working together. But even in some circumstances, there might be something where I just can't tell what it is on ultrasound, and then I say, "Hey, can you just go ahead and send her to me? I can scan her myself. We can see what's going on." And so a lot of times, or in some situations, complex situations, they will send the patient, and that's just how it is. But by and large, we're able to figure things out remotely. But again, it's because we've been so committed to making sure that these patients receive quality care.
Definitely. And just as background for the audience, both Amy and I started out at Harvard affiliated academic programs before we took our roles and our current roles. Amy, how do you are there some differences you noticed in terms of like resources, I guess in terms of resources or people resources, comparing the kind of two types of settings?
Sure. Well, one thing I will say is just in the states. So if you look at like Massachusetts, where I used to practice, versus Missouri, the climate or the landscape for health insurance, I would say by and large, is a little better in Massachusetts and Missouri. So that's, something right off the bat. I felt that when I worked for the Harvard system, that there were abundant resources available for patients. And when I got to my job in Kansas City and trying to serve this area that really needed subspecialized breast care and access, I quickly learned that I had to figure out a lot of things by myself. I needed to figure out, how can I reach these patients who are underserved, underinsured, who are the main players that we can work together to serve these patients. We also work together very closely with different organizations like Brock Couture KC, which serves underserved and underinsured patients, American Cancer Society, Kansas City. There's so many, Gateway to Hope. So it isn't, just about what can the hospital system do for you. It's who are the other, players in town that we can work together to better serve our patients. Like I said, a lot of times with these other facilities that I oversee, we'll bring them to Liberty for advanced testing that they wouldn't have access to care otherwise. Another great example is our true bona fide safety net hospital in Kansas City called University Health Truman Medical Center. They'll send patients to Liberty for genetic counseling and testing because they don't have a genetic counselor. We have a genetic counselor. We waive the consultation fee. We make sure that even if a patient doesn't have insurance, the most they would have to pay out of pocket is $250, if that, which they can be put on a payment plan. So I've really had to, over the years, figure out, what resources sort of exist in the different areas of town and how can we come together to work together to make sure that our patients aren't left behind and that everybody has access to the different services they need.
It definitely you have to talk to people, find out the resources, and just to add on to that, I feel like in the kind of in more in the in my prior position, I really focused in on the imaging, and I knew at the end, when the imaging was done, if that patient needed further care, likely it would be taken care of. You could just kind of pass that patient along. Where in the current role, we really are starting at that diagnostic. As soon as we kind of get a sense that this patient potentially is likely gonna have breast cancer, we're starting to think about how are they going to get treatment, where are they going to get treatment, and how do we usher them through this process as seamlessly as possible. So definitely a lot more involved in that area. We do have a question from the audience. I think this is a really great question. This is your part one of your expertise areas, Amy. How important is branding and social media in building your breast imaging practice?
So I think that it's really important, but I'm biased because I am, one of those social media lovers. I'm also an associate editor of digital media for the Journal of the American College of Radiology. So I have the privilege of working with really brilliant minds to bring digital content to the journal. But I think that branding and social media for breast is arguably becoming more and more important. I think that when it comes to breast marketing, it's becoming very competitive, and depending on where you practice, it's even more competitive. So, like for example, I didn't feel the competition as much when I worked in Boston, but when I got to Kansas City, I thought, gosh, this market is very vociferous about marketing and different breast centers and institutions, and I think it's like that in a lot of different parts of the country. I also think it's important so that the patients and the community know what services you provide, the quality of care you provide. Maybe you provide something unique that other breast centers in town don't provide. Like we're doing a lot of AI things at our breast center at Liberty and getting the word out so that patients have options. I'm a strong believer that patients need all the information to make the best informed decision for themselves. So I think that if you can get that information out there for them to really digest and see where they want to go, I think it's it's a win-win. So there's many of us in practice that have really worked to build the brand, build our social media presence for our breast centers and for our breast programs. So, one thing I haven't touched upon is, working in Boston at Harvard, everything's at your fingertips. And when I started this job at Liberty, we didn't have a genetics program, we didn't have a plastics program. So soon I wasn't just a medical director of breast imaging, I sort of oversaw our whole comprehensive program. We just brought on a new breast surgeon this month. So, I have monthly marketing meetings with our PR and marketing team and making sure that we are getting that information out to the community, not just about the imaging, but the comprehensive breast imaging or the comprehensive breast experience. Because as all of us know, it truly takes a multidisciplinary team effort in serving these breast patients.
Yeah, it really provides a tool for you to advertise, the great things going on within your program. I know there's many geographically, there's some areas where, pretty much like every practice has kind of a 30 or 60-day wait for patients to get in. So if you're one of those centers that can kind of figure out your processes, be efficient, and to cut down that wait time, that's a way you can really kind of dip into the market and attract more patients. And I think with the social media, it's also a great way to provide patient education. The patients are on these social media sites. So like you mentioned before, Amy, they want to be educated, they want to be knowledgeable on this topic. So to be able to kind of share information on, when you should be screened or just specific issues related to breast care, I think it's really important. It looks like we have another comment, another question here, and let's see. How can we improve breast screening access in rural and inner city communities? And do programs use mobile mammogram machines?
Yeah. So again, I think I sort of touched upon this. I think that coalition building is really important. So in Kansas City, I'm a part of what's called the Breast Cancer Health Equity Task Force. And this is a task force that brings together multiple different stakeholders across the city, from different health centers, from different health systems, different organizations. And we work together, and specifically, the goal is to reduce breast cancer death rates, particularly in underrepresented minorities, including Black women. And so, what we are strategically doing is working on, we are first focusing on counties that have the highest breast cancer death rates. And from there, what we're doing is partnering with local health departments, having different screening and educational events, making sure that if a patient needs a mammogram, maybe their health department has been contacted and they need a mammogram, that we make sure that we plug them in. This is a task force that has formed a few years ago, and it's been challenging. I'm not saying we put it together and everything got fixed. It's really taken a lot of time, but we've noticed that pulling together resources, coming together, really focusing on the counties that need the help the most, and then sort of working our way down, has proven to be effective. And also in terms of mobile mammography, we in our sort of area right now, we only have an outpatient imaging center that has a mobile mammography unit, which we have worked with them to see if they can help provide screens for these patients, particularly at screening events and that kind of thing. Mobile mammography, I do think, is a wonderful thing. I think that it can be challenging to implement in many cities, and I think that's why we don't see it as much. That's something that I've looked into as well, that I'm continuously working towards obtaining. But just getting a mobile mammography unit off the ground and then sustaining it, it is quite a lot of work. But if you can do that, it can be a great resource to provide access to care for patients. And I think it's something that we need to really push for in the years to come, so that we can make sure that regardless of geographic location, that women can get screened.
Those are great points. You got to get out into the community. And I think one of the an additional point is just kind of, and I know Amy agrees with this as well, is like really focusing on the quality of the program and access of your program. It's really hard when you get these women in who are willing to come in for screening and you have a long wait time, that's just going to increase your rates of like no show rates, even if you do get them to get an order for them or get them signed up for an appointment slot. So, really cutting down on on that wait time and getting your next available appointment times down. Focusing on convenient care is something as well. Are you able to do that same day diag potentially, on that suspicious finding? Are you able to do a same day biopsy, for those patients, who do come in and who are likely to be lost to follow up? So you really just kind of want to build your program and making it as convenient as possible for patients. We do have a mobile mammography program here at Denver Health, and it's been great. A lot of our patients, they want to be seen in their communities, and it's almost a challenge to get them to come downtown to our main campus. So you really just kind of want to be able to leverage, both resources, kind of your main sites and your mobile mammography units, and really try to kind of meet the patients where they are and kind of meet their needs in terms of what they are requesting or desiring for service. But great question. Amy, I know your site has patient navigators. Have you utilized them, and what's the way that community, in these settings, you can utilize them to optimize care?
Yeah, so I think that navigators are utilized in different ways, and honestly, until I got to where I am now, um, I saw navigators being used in a different way than how we're using them, I guess you could say. So, in fellowship, specifically, my first job in Boston, when we had nurse navigators, they specifically were on the imaging side and specifically would help with, helping schedule patients for biopsies, calling patients with biopsy results, any questions they might have along the continuum of cancer care, that kind of thing, which we still have with our navigators at our breast center at Liberty. But we do it a little bit differently in the sense that once the patient is scheduled to see the breast surgeon, that first appointment, one of our navigators actually goes to that appointment and works with the breast surgeon and works with the patient. They put together a binder of educational information for the patient. They make sure the patient's scheduled after they see the breast surgeon with who they need to see, whether it's, if they need a breast MRI, whether they need to see genetics, whether they need to see breast oncology. So they play a very big role in the care of the patient. Our patients really like it. Our patient satisfaction's really gone up because we have this navigator that's sort of bringing everybody together, the whole multidisciplinary team. The navigators know what's going on in all the patients. I may only know what's going on with the patient on the imaging side, but I can ask one of our navigators and say, hey, what happened in this appointment with the breast oncologist, or what happened with the breast surgeon? And they'll know, what's going on. So providing that care, I think, has just been wonderful. It's really enhanced the quality of care for patients, and our patients know who to go to if they have a question. They don't feel as alone. It's very personalized in that sense, and obviously it's very time intensive. But if we're really striving for personalized breast care, particularly in this era, we're going to have to carry out measures such as these. And for us, this patient navigation setup has proved to be really successful.
Yeah, you're really extending the influence and the impact of kind of the breast imaging center and the radiology throughout the entire process. And I think that continuity really supports patient care. And then navigator, I'm assuming, I know that our navigator as well, they can provide, resources. One thing that's not talked about a lot, but just kind of, the mental health and psychological impact of having a breast cancer diagnosis. There's so many resources in the community where you can connect patients to kind of help support them through this new diagnosis and kind of help usher them through the process. So, having a navigator is amazing. I think any program that has a navigator, once you have one, it's hard to think back before when you didn't have that navigator, just because they are such a positive, just because they are such an asset to every program as well. Let's move to the next question. Or I will comment on one thing in terms of the navigators. Sometimes it's hard to to secure funding for navigators. There's only so many dollars that are allocated for certain positions or whatnot. So I think understanding or qualifying why you would need a navigator, and understanding those points that hospital leadership want to see to try to get those positions approved. But there's other avenues. For our navigator, we applied for a grant and had it funded through that way. So writing up a research project and going through private industry to kind of the navigator funded. So there's different ways you can have a navigator funded, and once you have that navigator on staff, that's when you need to start accumulating data showing what their worth is and how it's really contributing to the hospital. And I think that's how you can start making these positions more of a permanent position versus kind of a temporary or research or a temporarily funded position. So.
Yeah, and another way that, you can, if you're trying to justify a hire or you're trying to get funding for a hire, is going through your foundation. So, specifically, what we did with our genetic counselors. So, genetic counselors, by and large, to be, very honest, they're not obviously revenue generators, but what they provide, the value they provide, is so invaluable to a health system, and they can be such a critical component to making sure that patients are kept within the system, right? So it's not necessarily a direct uh, sort of I guess you could say from a financial aspect, like a direct ROI, when health systems have to look at what they can afford, what versus what they can't afford. But throughout the continuum of care, I think genetic counselors provide uh, such an invaluable role. So what we did to justify the hire of a genetic counselor and starting a program is we actually got the first year of the genetic counselor's salary funded through the foundation. And then from there, once that year passed and we were able to show that she is invaluable to the institution, look how many patients she served, look how many cancer patients we're able to keep within the system to make sure they have access to her close to home, then we were able to roll her salary and benefits into the hospital budget. So, you could go that avenue as well. So, like, Randy was saying, that there are just different ways that you can get funding for these really critical positions for patients.
Yeah, I love that term ROI, return on investment, and it's different for each hospital. So you may need to meet with hospital leadership and understand what they're looking for, or create like a plan so you can kind of keep track of those metrics or numbers or specific data points that can help support whether it's a navigator, MA, or any type of position that's going to help you become more efficient and provide better care for your patients. Let's see. And you've kind of touched on this, but I'm curious, like, what is your approach to patient education in breast imaging? How do you see that for yourself?
Well, I mean, my approach is that I want to equip patients with as much information as they have so they can make the best informed decision for themselves. I'm very transparent with patients. If I know they have a cancer and I go talk to them about their diagnostic breast imaging eval, I'm going to tell them, like, this is going to come back a cancer. I don't sugarcoat it. And I always tell them, I'm not saying this to scare you. I just feel like I owe this to you. I know, I owe this. I feel that I need to be transparent with you. I think that patients really appreciate that, so they have time to process what is happening to them. So by the time you do see them for the biopsy, they've had a little bit more understanding of, this is what's happening to me, and let's move head on. But I think patient education comes in so many forms, not just talking to the patients, but like we talked about, social media is a great way to educate patients accurately, reaching patients we may not have previously reached, such as patients in rural areas. I think that's important. I think that online education is important too. We're currently updating our website with patient education pages. That's something that patients can refer to whenever they have a question about the numerous services we provide, or about their biopsy, or what have you. But also, patient education comes in different forms. Our nurse navigators, we've worked really hard to educate them to make sure that they have so much knowledge. I always joke with our navigators that, gosh, you could probably just do my job now. I mean, you're just so adept at you have so much knowledge for breast cancer care and breast imaging that I don't even have to worry about what they're saying on the phone, because I know they have it. They understand it. They've studied it. So it really does take a village. And I think patient education comes in all forms, and we need to be equipped to provide that education in all forms for our patients.
Definitely. And you have to utilize your resources, like, as you mentioned, with the navigators. And a lot of patients, have questions that may not even get to us. So I think educating, like you say, your navigators and even your technologists, because a lot of times, patients will ask the technologist, and, even thinking about having an efficient process, if they are equipped with the information, comfortable with some of these topics, you know, that can really help to decrease, especially as we're talking about staffing and, really having to be very efficient as the radiologist. The technologist is able to relay some of those, like, and answer questions for those simple topics and help the patient feel comfortable on those topics. It really can make your practice. You can just optimize the time that you're utilizing for your practice, and really focusing on the areas that you need to focus in on. And then on and patient education materials, as you said, like, being able to hand out materials can really help, as well. We've created a lot of documents on, the difference, between 2D and 3D, on advanced technologies that we can, hand out to patients, just to kind of educate them and provide them the information so that they can make educated and informed decisions about their breast care. So, all great points. Let's go to our next question here. How do you build research and educational programming into community programs?
I think that this is very challenging. I think that maybe there's not a one size fits all approach, that maybe some community programs it's a little bit easier than others. But I have found that specifically where I am located, it can be very, very challenging. You have to have a buy in from your leadership. So when I arrived and took over as medical director in 2018, at our health system, there wasn't a lot of research happening. And, also, in addition, I have a faculty appointment at the University of Missouri Kansas City, so I do have support as well for research at the School of Medicine. But clinically, where I practice, I needed the support from the C-suite as well. And so I had to sit down with them very early on and say, these are the things that I'm really interested in. These are the research opportunities that exist for us, and how I think this could enhance patient care. Luckily, we have wonderful leadership that really bought in, and we started pushing the boundaries of what the health system would used to historically sort of carry out, versus now where we are encouraged. If we want to do research and things of that nature, we definitely are supported. So that's wonderful. Educational programming, I mean, even simple things such as also another hat I wear at the hospital is I chair the CME program. So I work with our med staff to have quarterly grand rounds and just educational programming for our providers. We're talking a lot about patients today, but I think educating providers is equally important. There's so many things changing in breast imaging, for example, as we know, with MQSA and FDA, with breast density recording. There's a lot of confusion along those lines of breast density and what to report to patients. And I'm getting a lot of questions from referring providers. So if we can educate referring providers, not just on breast imaging, that we do for these grand rounds, but all aspects of medicine. I think it's important. But again, it takes a lot of work. All these things, my old job were already in place, right? I worked at Beth Israel Deaconess. We have robust research and educational programming, and that academic mission really was apparent. But where I am now, it sort of took a little bit more effort to build, but it can be done. But again, there are other community based practices where this is already in place, especially if they are affiliated with a large, academic, research driven health system. Then those community hospitals may already have these resources in place. But if you're somebody out there listening in that doesn't have that but wants that, it can be done. It just takes a little bit more work.
Yeah, I think those are great points. I'll just add, if you are in a smaller setting or a community setting that's not affiliated with the academic program, you can always reach out, to those programs that are in the city and, and see how you can contribute. There may be time, for contributing your data if you really want to kind of go in this direction. One of the big reasons that I really wanted to build the research kind of pillar at Denver Health is really, we really want to know what's going on with our particular patient population. What trends are we seeing? Because that information that you gather can always be turned around, evaluated, and flip back to improve patient care. Okay. In terms of, in terms of starting off, I would, look into talking to leadership or your chair to see like what resources can be made available, um, you know, with this, I think my chair in particular is very supportive and able to come back to the hospital. So if you can, as we were saying with the navigator and some of those things, if you can kind of, provide data, provide metrics to show like how this is beneficial, you can utilize that to get, more time, potentially, direct funding from the hospital. And a lot of these hospitals do have pilot grant funding. So that's something you can look into if there is like small seed funding that you can use to gather data to think about pursuing, further, bigger awards and greater funding. And the last thing about educational programming, don't underestimate the ability to start educational programming in the community setting. We were able to start our own breast imaging fellowship program. We created a curriculum. There's numerous resources out there that can help with, with the educational components, such as like virtual lectures. Really utilizing all of your resources, you really can build this arm of your program. But like Amy said, it does take a lot of work. So you really do want to take time, talk with leadership, see how you can maybe, get a little bit extra time to get this set up. But once it's set up, it really will, contribute to your program in so many ways. Let's move to our last two questions here. Amy, especially with your role as, the chair of the ACR RADPAC, I'm curious, what do you wish policymakers knew about, I'll say, community and safety net hospitals?
Sure. I think that, and this is of no fault of policymakers. They have so many things that are being thrown at them. They may just not have the knowledge on certain aspects. I think that, we always push, particularly with RADPAC and with ACR government relations, is if you're in a position where you can invite a policymaker to your health center, to your breast imaging center, or to your departments to see, what do you do as a radiologist? What the integral role that you play in patient care. uh, Go over and talk to them about what is this equipment, what is in this room. I think it can be really effective, and I think that that's why we've had such great success in Missouri with passing critical pieces of breast imaging legislation, three pieces actually in 2018, 20, and now 2023, because we brought our policymakers in to see what we did and why we needed access to care when it comes to 3D mammography, above average risk imaging when it came to diagnostic breast imaging coverage without copay or deductible. So just educating them, bringing them into our world is really important, but also making them cognizant of resources that they may not be aware of. So, for example, in Missouri, if you're at the 200% poverty level and you feel a lump and or pain, you need some sort of evaluation from an breast imaging standpoint. You can qualify for what's called the Show Me Healthy Women program. The equivalent program on the Kansas side is called Early Detection Works. And these are great programs that can provide funding for patients for imaging. And then if they are diagnosed with a breast cancer, they qualify for what's called BCCT Medicaid. And then they're covered for all their oncology treatment, surgery, etc. But it seems like every year this funding's on the chopping block in the Missouri legislature and in the Kansas legislature. So making, for example, our state policymakers know about how critical these programs are for access for underserved patients, so that they can vote in favor of it continuing on to fund programs such as this that are so critical in these parts of the country, is really key. So the knowledge that we have, they rely on us as experts to provide that information. So reaching out, forming relationships with these policymakers is really important if we're going to ensure that our patients continue to have access to life-saving examinations.
And I guess for just a kind of a secondary question related to this, for our breast imagers out there in the community and safety net settings, what do you want? What do you? I think there. What do you think? What would you like hospital leadership or chairs?
I'm sorry, you cut out a little bit. Can you
Well,
repeat the
sure.
question? It might be
Yeah,
my
sure.
internet.
Looks like I had a pause, but for hospital leadership and for chairs, what do you wish they knew about breast imaging? We have a lot of breast imagers here who are kind of working through some of the issues that we talked about. How can they support their breast imaging leadership?
Sure. I think that whether you're a chair or you're president of a practice, of a private practice, I think it's important for those people at the highest levels of leadership to truly understand the issues. Listening to what is plaguing our departments, I think it's really important so that they can advocate for us in situations where we need them to advocate on a higher level to make sure that we have access. So I just think that continuing having strong relationships, keeping that dialogue going, the communication, making sure that they're well informed about the issues is really important to make sure that you have the access, that you have the resources that you can provide access for your patients. Randy, I know your chair is really wonderful. I know when you came in, you had lots of discussions with him about what you needed for patients, and he really, seems like this is a person of leadership who gets it and really helped work with you to make sure you had the resources for your patients. So I think that the more and more leadership we have, such as this, in terms of listening to us, knowing and understanding the issues, and able to advocate for us, can make all the difference for patient care.
Great. And then we'll move to our last question. I know we have a few minutes left, but what is your vision for optimizing care and breast imaging in the future?
Wow, that's a $1 million loaded question there. I, there's so many challenges obviously that are plaguing us, not just in breast imaging, but radiology and medicine in general. But, I'm sort of the eternal optimist. I'm excited about the field of breast imaging. I'm excited for all the technologies that are coming out. For me, it would be wonderful if we could create, quality standards, that if whether you're a patient that's getting treated or seen in a rural area, you're getting the same quality care as a patient in maybe a more urban city setting or suburban setting. I have a clinical interest, as you know, in AI. I do feel that AI is going to make us better as what we do as breast imagers, and making sure that everyone has access to AI, not just the big, large academic health centers, but or health systems, but even rural areas. Even though at this time implementing AI in a lot of these areas can be very challenging, just even simply due to things like implementation and internet connectivity and how fast your internet connection is, things like that. So I think that we just have to continue to strive to optimize care, and especially like I previously touched on, breast is becoming so personalized, and making sure we're able to provide that personalized breast care for each patient, that we can properly risk assess them, whether they're in a large academic health system being seen, or they're in a small critical access care rural hospital in Northwest Missouri. Making sure that we're optimizing care for our patients is truly what is the most paramount.
Well, thank you so much, Amy. I feel like there was so much that was shared today that's so helpful for providers who are practicing in these settings. Make sure to follow us on X, formerly known as Twitter, at the JACR Journal. And then we also have our handles here on X if you want to continue the conversation on social media. I know Amy provides a lot of educational materials, as well as I do as well, just on breast imaging and other areas as it relates to policy, care, and clinical care and research. So thank you so much. And I do want to highlight our next winter session case, episode 2. Our host, our guest host will be Dr. Anand Prabhakar, who's the chair of Newton Wellesley, affiliated with Massachusetts General Hospital. We'll be talking about the business of radiology in community settings. Thank you for your time, and thank you, Amy.
Thank you.